Welcome to everybody. It is a great pleasure to welcome you to this information session about the new stage of our National Autism Programme. A warm welcome. The Anna Freud Center, in partnership with Autism, have been commissioned to develop and deliver this program across a range of mental health and social care settings from now until 2025. These include adult and children and young people's inpatient clinics, all-age community services, secure welfare and youth justice services, as well as special residential schools. This is a train-the-trainer program, meaning that those who are trained with us, they will be afterwards supported to co-deliver this training in their services and be part of our very active community of practice. This training is co-produced and co-delivered with autistic people. Everything we do is with and for autistic people. We have over 30 autistic people who are content developers and delivering the program along with another 60 neurodivergent trainers. Our program aims to ensure that autistic adults receive appropriate care by reframing the narrative about autistic mental health. My name is Georgia Pavlopoulou. I'm the program director for Anna Freud Center. And over to Ruth.
Thank you, Georgia. My name is Dr. Ruth Moyes, and I'm a director at Autism. Anna Freud and Autism joined forces in November 2021 to develop and deliver the initial pilot, which was externally evaluated by the Royal College of Psychiatrists. And based on the success of that programme, we are now here today to share the next steps with you. As we get going, please be aware that the webinar is being recorded and you'll be sent a copy after the event. There'll be British Sign Language interpreters throughout the event, along with closed captions. And please do submit any questions via the Q&A feature, which can be found at the bottom of the screen for our Q&A panel later on. And finally, please be aware that some of the testimony that we'll be sharing with you today is deeply moving and difficult to hear. We share this in a non-judgmental way so that we can remind ourselves of why this programme is needed and of the need for us to work together to effect the change that we want to see. Thank you.
First speaker for today is Professor Peter Fonagy, CEO of Anna Freud, professor at UCL, and he's going to remind us of the national picture and why this training is needed.
Good morning. I'm Peter Fonagy, and I have the privilege of being the Chief Executive of the Anna Freud Center. I'm delighted to be introducing this training program this morning, a training program that we are enormously proud of actually beginning to deliver. Why is this training needed? The training, I believe, is needed to radically alter the experience of autistic people in all the services they come into contact with, because we have had so many reports of less than adequate care. What we hope it will achieve is enabling staff across all age, mental health, secure and residential settings and youth justice provisions to have a much better understanding of the needs of autistic people and adjust their approaches in response, which will enable better care. I think it's important to underscore that it's not just about understanding, but what we hope is going to create a change that's desperately needed, a change in the way professionals behave when they encounter autistic people. It's a training that has been completely co-produced and is co-delivered, ensuring that autistic people are central to every aspect of the training that we offer. The training fits with the centre's strategy, the strategy that we call closing the gap. the National Autism Trainer Programme is a key part of us being able to close the gap, by which we mean to improve the knowledge, the skills, and the confidence of professionals, and in fact all those working with children and young people in whatever capacity across the United Kingdom, who are involved in delivering or potentially delivering mental well-being support. We want to achieve this at scale. We want to change the narrative about children and young people's mental health. The National Autism Trainer Programme is a great example of how we can achieve this. We can do so with innovative approaches, drawing on the expertise of people with lived experience and adopting a train-the-trainer model. So the National Autism Trainer Programme is a core part and a good illustration of what we hope to achieve in our Closing the Gap strategy at the Anna Freud Centre. And with that, thank you very much for listening. And I hope that today's events will justify my confidence in the programme to deliver a key part of our mission at the Centre. Thank you.
So next, we're going to hear from our commissioners, Team Devanney from NHS England, a little introduction to the programme and what do we aim to achieve. We have Team online with us today. Good afternoon, Team. It's great to have you with us today.
Hi, good afternoon. Hi. So for some, this will be an introduction, and I guess for others, perhaps this will be a reintroduction. This is a training program, an intervention that's here by an iterative process. It's a program that's been designed, tested, adapted, and we've repeated that process at each stage, improving and in fact growing the work that we've done. It's evolved as we've learned and understood more about what's needed. Perhaps if I start you off back at the very beginning, it started back in 2019, following a series of CQC reports and other damning reports regarding the treatment of children and young people in mental health inpatient settings. For some, care was frankly inadequate, for others harmful. Repeatedly in those reports, it highlighted the worrying fact that staff in those mental health units were not getting the autism training that they needed. They were often understaffed, and the staff that they did have was often temporary and had high turnovers. And we recognised that we needed to put some training in place that would meet the needs of those staff and meet those challenging environments, those challenging working environments. So we recognised that mental health environments themselves are particularly challenging for the children and the majority of children and young people, but especially challenging for our autistic children. We recognised that the training that we need to offer needed to go beyond that which we would typically see in autism training. And it needed to cover elements such as the environment. We needed to think about institutionalisation, trauma, address directly sensory needs, and the importance of routine. We needed to be cleared with staff that because an environment and a service may work for most people, it doesn't for one instance mean it will work and be suitable for an autistic person. So we pulled our stakeholders together. We pulled every learning development and service manager of inpatient units, children and young people, together into a room back in November in 2019 and looked very seriously at what training that we need. We asked them to bring their experiences, we asked them to bring some of their children and young people and their experiences with them. And we started to draft out what the training should look like. We knew from the get-go it needed to be co-designed and co-delivered. They told us they wanted quality assured materials and consistent content. It needed to be a flexible delivery that would work for staff, regular staff, but also for staff that were coming in on temporary flexible measures. And it needed to be fitted and fitting to each specialist service. Where, you know, for example, if a unit was particularly focused on eating disorder services, and it would need to fit for those in a different way to other services. And finally, we needed something that had a network and support for trainers. So that's what we set out to commission. That's what initially the training looked like, and that's who it was delivered to. It was delivered to all inpatient services where they were offering child and adolescent mental health services. In 2021, we realised that actually this is beyond children and young people, a need beyond just children and young people, and that we recognise that we need to expand into adult mental health inpatient services. And that was the original pilot that I think was referred to earlier. Again, that was evaluated. It had lots of successes, and we'll talk about some of the learning as well later. I think we'll hear about some of the learning from those evaluations. But what was key was, again, we recognised we needed to expand not beyond the walls of inpatient settings into communities to help teams better care for their autistic communities in ways that meant that they wouldn't need inpatient facilities, in ways that would prevent that sort of deterioration, and beyond that into secure welfare, youth justice and residential schools. So what I think we have now is a training that is that offers consistent understanding, a consistent use of language, consistent approaches across all care settings. So that as people move through different care settings, they can expect their staff to have similar understanding, similar levels of the knowledge and skills that they need to prepare and provide appropriate care. A training that is at its core developed by autistic people, co-production being that core element, and co-delivery being the only means of effectively delivering this training. It recognises that trainers must be supporters and offers the trainers that support. And the end point, the whole point of this is a change in culture. It's a change in culture that after this intervention, that training becomes business as usual, that this understanding, we know that staff will need to be refreshed and recognised and hone their skills going forward. So that's why it's a train the trainer programme, so that we can build this into business as usual. And it sits alongside the other learning that's associated with this. So it sits alongside Oliver McGowan mandatory training. It sits alongside and works with peer support worker training. It sits alongside and works with trauma-informed care training. So I hope that I've given you a good flavour and an introduction, and I'm sure our colleagues will take you through and give you more of the understanding that you've come from today.
Thank you so much, Tim. Such a useful overview. I wonder if you want to share, if you have a moment to come back. Yeah, if you want to tell us what is it exciting to you about these programs and what outcomes? I think you covered already some of the outcomes that you would like to see. What is it exciting to you about this program?
What's exciting is essentially two things. One is we've got training that's co-produced and co-delivered by people who really know their stuff, by people who can speak from experience, but by people who are trained to get their points across in meaningful and powerful ways. So we've got the means for change. What added on to that is we've got the opportunity for change. So we've got an opportunity to get those core messages and that core understanding through to all mental health services, through to not just the inpatient community, but our community teams, our liaison teams. We can, if you like, inculcate the understanding that's needed and so sorely missing across the whole of our mental health, secure welfare, youth justice, and special residential school settings. Now, that's big and that's powerful, and what's not to be excited by that?
Thank you so much. Thank you. I'm sure we're going to hear a little bit later during the Q&A panel. Thank you so much. Next, I'm very, very excited to share with you some of the stories from people who have been very core to our program, people who are autism trainers, people who are scholar activists, and have been very much working with us from the very beginning as content developers. First, I would like us to hear from Alexis Quinn. Alexis Quinn is an autistic activist and author of Unbroken and Autistic and Expecting. She has been in inpatient care for 3 years, and she has been supporting us with co-delivery, co-production of different material. Over to Alexis.
It's a pleasure to be able to speak to you all today about the importance of this training, mostly because it's training that I think would have benefited, the hundreds of staff that cared for me when I was detained in mental health inpatient units over a period of just under 4 years and in 12 different care settings. So in the time that I was detained, I found that staff didn't really know what to do with me. They seemed to either understand autism as a condition that couldn't be treated, and therefore didn't bother and had no aspiration for me, or they believed that autism could be eradicated, in which case I was subject to, behaviour modification training. Now, either perspective, led to feelings of, I think, isolation, anxiety, alienation, and I think of fear of people and staff and others, and that led to me getting really quite distressed at times. And too often, restrictive practices then happened, where staff also sort of got caught up in the cycle of misunderstanding what was going on for me, distress, then restrictive practice, and then repeat, misunderstanding, distress, restrictive practice, and then repeat. And in the end, I was held, multiple times in solitary confinement, a place where I consider ultimately I suffered a kind of social death, where I was starved of meaningful human contact. And I was told that autistic people like to be alone in sensory and socially deprived spaces. And as I grew more fearful of people, as I grew more sensitive to sensory input, because I was so starved of those things, that was used alongside a diagnosis of autism to justify my need for that very impoverished environment. And that's to do with a real misunderstanding, isn't it? A real myth, actually, about autism and about autistic people. So if only staff really had understood that my autistic needs were also human needs, that we too love, that we too communicate, we interact, we engage, we participate in stuff, right? Not activities of daily living. And that we too enjoy, being with people who care and are empathic. And we all know, don't we, that this autism education isn't the answer. But what we do know is it is part of the solution. So for me, this co-produced training will enable staff actually to understand what autism is and what it means to be autistic. It's been designed and written and will be delivered from an autism perspective, an autistic perspective. And I wish, that those people, that had been supporting me and who I sometimes come into contact with even now, staff, I wish they had this training. Because if they had that, they might be able to recognize, that my behavior, is more than an expression of a defunct, disordered person. They might have had the knowledge and understanding and the skills to see me as human. And this is massive because, when we see similarity and we understand difference, then we can empathize and we can show compassion and we can even show love for people. And I just want to tell you a story which I think really illustrates this point, which happened to me. I was being transferred out of a 28 days in solitary confinement, and I was handcuffed. There were 4 staff in the caged vehicle. I was in a cage. I had leg straps on, so my legs were tied together. I was handcuffed, and the journey was 4 hours, and I was soiled, because there's no toilet and they weren't going to stop for me. And I arrived at this low secure hospital, which is where I was being transferred to. And the staff opened the door, and there were the 4 of them sort of flanking the doors, not that I could really go anywhere because my legs were tied together. And they got me out and I was all sort of tied up and they were holding, me in restraints under my armpits. And nurse, who I knew her very well from a number of years before, she said to them, take those handcuffs off her. Take those leg straps off her. And the staff were like, no way, are you for real? She's like, take them off. Anyway, reluctantly, they took them off. And as I said, I was soiled, I was upset, and she just gave me a big hug, she squeezed me really tight. And she told me I was safe. Now, I think this story is important because that nurse was able to see me. And that's what I think this training could enable staff to do. It could, to see us, to see autistic people for who we are, human too.
And that's why we're trying to do what we're doing. Next, it's a great pleasure to have with us Andrew Carpenter.
Thank you. It's very hard to follow Alexis, isn't it? I'm Andrew. I am autistic and I am the autism lead for London with NHS England. That fact shouldn't be remarkable, but sadly it still is. To have an autistic person in a, I suppose, relatively senior role about autism. But it is remarkable to have the autistic voice actually at the heart of the conversation and narrative about autism. And that's why I think it's so important that this training is not just co-produced, but actually genuinely led by autistic people at the very heart of all that is being designed and delivered. It's also why I think we've got our understanding of autism so wrong for so many years. The narrative on it has been led by non-autistic people. Now, I'm not here to say, by no stretch of the imagination are things perfect in other minority groups, but at least I think there would be a finger of complaint in the air if conferences on other minorities were led by people who were not from those minorities. But the fact is, there's not even a finger of complaint in the air by the fact that the narrative on autism is still led by non-autistic people. And that remains such a big problem, I think. For too long, we have been using the wrong yardstick to measure a happy, successful autistic life by. We've used the yardstick of a happy, successful neurotypical life and asked me to measure up against that. In fact, I've been sort of rewarded, clapped, oh, well done, the closer I've appeared to be looking neurotypical, as if that was something good to achieve, to be less of my authentic self. We don't celebrate that in any other areas of life, do we, normally? But what we also know, and here are some rather tragic facts and stats for you, is that the very act of that, the fact that best practice, in good faith, to be fair, was often aimed at delivering that to make me look less autistic, has led to so many of us dying. And I'm not being over dramatic when I say that. We know that statistically, autistic people without a co-occurring learning disability are the most likely kind of person to die by suicide. Up to 9 times more likely to do that. We know we die far too early, 16 years or more, and one of the 2 major reasons for that is suicide. But we also know that suicidality correlates directly with the act of masking and camouflaging our autism. In other words, being asked to measure up against that yardstick of something we're fundamentally not. Being asked to be less of our authentic self. And the only way we can change that is to understand and hear the autistic voice, that we are not broken, we are not faulty, we are just different. And that means changing the whole therapeutic approach as well, because traditional approaches rarely work for autistic people, because frankly, they are delivered in a foreign language called neurotypical. At the heart and one of the pillars of my diagnosis remains the fact that apparently I have a social or communication disorder. Well, I think we're kind of not doing too badly today. Most people in the room seem to be getting it. But we also know from research that autistic to autistic communication is not just as good as neurotypical communication, it is better than neurotypical communication. That means that evidentially, I don't have a communication difficulty. I just speak a different language, not a faulty one. It means that therapists need to learn to translate what they're doing into my language. Because even when we talk about meeting in the middle, the autistic person is already in the middle because we've been forced there just to live in a world that doesn't accommodate us very well. And I know that this training, co-produced by autistic people, will help people to understand the need to change that therapeutic approach. I think my 5 minutes are probably up, so rather than bore you any longer, I will concede the floor. But thank you for having me today. Greatly appreciate the chance to speak to you. Thank you very much.
Thank you so much, Andrew. And next, I'm going to call Lauren Fernandez. Lauren is going to talk about her experience, and she has been as well one of our key co-developers.
I'm Lauren. I was diagnosed autistic and ADHD aged 26 after a lifetime of struggle and confusion. In the 18 months that followed, I was denied therapy and other services due to the age of being diagnosed. I lost my job due to disability discrimination. I became homeless after an instance of domestic violence. I sofa surfed in an area I had not resided previously until being temporarily housed. I had a car accident with a bus, which brought back, sorry, I forgot to mention that I have got a content warning here. I had a car accident with a bus, which brought back residual trauma from a previous sexual assault. I lost my job again due to harassment, being unsupported, and my inability to cope with everything going on. I was raped in my temporary accommodation, disbelieved, and uncaringly made to live in the exact same room and bed for over a year. I was stalked and harassed at the same accommodation for threat of going to the police. I then found myself in another abusive relationship, resulting in my phone being smashed, is curvy, as you can see, smashed to pieces by hand. All the while, I was in frequent contact with the local council, my GP and housing officer, asking for support, medical care for physical manifestations of the stress I had endured, to be moved from a place where so much trauma resided with me, and to at least be given talking therapies to help me understand my recent diagnoses and make the right steps forward in life to enable me to stop perpetuating the same negative cycles. It was clear that no professional I spoke with had experienced anybody like me. I was laughed at over the telephone, denied support, told that I was very articulate and not in receipt of enough benefits. Over the following 6 weeks, my physical health continued to decline whilst I searched for the support I required and studied my rights. I received a further threat of homelessness, as the council would have expected me to stabilise my situation and find somewhere to live, having been housed for almost a year, unquote. From that phone call, things really began to spiral for me. Unable to sleep, rest, eat, and generally tend to my immediate needs until I was satisfied I would not be left on the street amidst the global pandemic, I was advised by my GP to contact 111 for out-of-hours medical advice and the local crisis line for somebody to talk to. I did not understand at any point that following this advice, along with interference from some that I deemed to be my support network, would lead to me being sectioned. I was sectioned 3 times in 3 days, twice by police, and then I was tricked onto a psychiatric ward. As if the police didn't manhandle me enough, I was dragged through hospital, had my pants pulled down by males, forcibly drugged and secluded within 45 minutes of being on the ward for disturbing other patients, all whilst I was silently protesting. Luckily for me, I was able to discharge myself after 5 days, but not before being denied reasonable adjustments, being continuously laughed at, mocked, dismissed, neglected by staff, assaulted by another patient, and being offered a bipolar diagnosis, which of course I refused. Released back into the community that had struggled to support me my whole life, more specifically over the past 21 months, I was subjected to secondary care where, although I took an anti-medication and preferred a holistic approach, such as the therapy I had been begging for, they demanded that I take a course of antipsychotic and antidepressant medications for at least a year before I would be ready to engage. I had a community nurse label me as labile in mood, aggressive and challenging when I asked what she would have done in my position and how she would respond after going through a fraction of the things that I'd been through in the recent months. I sought my own support from a Second Voice charity, whom I say saved my life, and for the first time, listened, heard, and supported me away from these volatile circumstances. I hope that by giving you an insight and a glimpse into my recent experiences, you can see for yourselves how vital this training is and how important it is to employ both an experience and trauma-informed approach. The co-production and delivery of and with autistic people, thank you. The co-production and delivery of and with autistic people in delivering this training is crucial in ensuring that the autistic perspective is not only included, but carried throughout the rollout of the training. Through the lenses of diversity and intersectionality, the programme rollout has greater ability to affect and improve the care and lives of other autistic people, too frequently unheard, unseen, and underrepresented, particularly when it comes to being included in our own care. Thank you.
And I have to admit, Lauren, you have been challenging. You have been challenging a lot of thinking about what needs to be done and challenging our thoughts about what we think we might be doing. So thank you. Thank you so much. So we had some narratives about why this training is needed from autistic people. And next, I would like to invite Anne Memut, Autistic Autism Trainer, content developer for our program, and wears many, many hats for all good reasons. And is going to help us to understand, it's going to give you a glimpse of how we're framing the work at the National Autism Programme. We very often talk in our trainings about collaborative, experience-sensitive and trauma-informed approach. Anne is going to tell us more about it.
Well, thank you very much, Georgia, and everyone else here. Pleasure to be here, and I'm sure you're as moved as I am by some of the accounts that we've already heard. It shows how important and how powerful this work is in bringing about real change, the sort of change that we need within the systems, so that we manage to not do this type of thing again. If we can have the next slide, that would be lovely. Thank you very much. And grateful also to my colleagues who are working the technology here today. As Georgia has said, I'm one of the associates for this, also an associate without autism, who are part of this whole program. Content developers, certainly it's been a pleasure working with that. More broadly, I'm an independent researcher, a lecturer, a trainer, 30 years of professional work in this field. I'm autistic myself. Been a carer since I was 10, believe it or not. It's quite an age, because I'm about to retire, allegedly. And I'm a parent of a fine autistic son. And quite often online we go by the hashtag of autistic elder, representing the years of dedicated autism we brought to all of this. The next slide, please. Thank you. Right, a quick run through of what we're doing here, because it is so important. Starting with the word respect. And what happened with Alexis, as we were hearing, you know, she went from a team that saw her as a prisoner to be feared and corralled into something, out into that relationship of respect, where she found someone who was able to say, you know, you matter, I care about you. So we need to reframe negative or limiting perspectives of the autistic community. We've got autistic voices centered throughout, properly centered. And the delegates are engaging with and amplifying those narratives of autistic people of all kinds. The slide materials that we're using throughout this program are made by and with the autistic collaborators. And it's a truly working relationship. And I use working in all its terms, not just being at work with each other, but making it work together. Also, of course, with so many other neurodivergent team members and our fabulous allies. Next slide again, please. Thank you. Collaborative. Yeah, we've needed to collaborate. We've needed to really get our proverbial heads together on this. It's about co-production and co-delivery, and those are not just words. It's absolutely at the heart of what we've been doing. And so our values, our approaches are curiosity about each other, you know, that empathy, that really wanting to know. It's about compassion for each other. It's about caring. But it's also about relationship. How do we best relate? How do we best understand that language that Andrew was talking about, that difference between autistic and non-autistic? Trust, desperately needed throughout our systems, throughout the care we're trying to provide. And that word again, respect. Every part of the process has been owned and shaped by this partnership of equals. you know, not us being brought in as an afterthought or as an addition, but very much embedded. And so that respect for skills and experience, the best ways of working for us, really makes a difference. Next slide again, please. And that collaboration goes on to co-delivery. So we're not only talking about people with lived experience from inpatient and outpatient care, and of course, their wider carers, their parents, those who love them. But we're talking about co-delivery of the training. So we're talking about training partnerships of autistic expert trainers, other neurodivergent experts by science, and neurodivergent academics, as well as allies. And we're asking people to join as trainers as experts within their own services. And so as they do so, we're so aware of the need to make sure that everyone is well supported. And so we're giving them these reflective activities to deepen their knowledge. Next slide again, please. Co-delivery leads on to good support as well. We're very conscious of the need to have really up-to-date collaborative materials, the best of research, the best of this thinking together, and allowing people to access that through the libraries. We've got a community of practice, making sure that people have that chance to reflect, to feel valued, to feel supported, and to also be able to talk together about these services. And we have guest talks as part of that from autistic experts. Good thought is given to ongoing training and support, safety and well-being, because we need it ourselves. You know, a number of us have had, you know, quite interesting situations, as you've been hearing, to say the very least. And so, you know, making sure that everyone is able to access that is vital. And as an important part of that, fair and timely payments. Lovely, because we've seen a lot in the distant past of autistic people being asked to work for very low money. We haven't got that here, hurrah. So thank you again to the teams for that. The next slide again, please. Now, during the training days, we're going to be exploring with staff different dimensions of these frameworks, these named frames, and talking about the practical applications of what they're learning. The autistic trainers will then train staff who will then connect to our experts by experience trainers to co-deliver this material within their trusts. And there's a very active, growing community of practice which keeps supporting staff to keep growing those skills. And we'll also make sure that there's a link, I believe, in the chat box about that for more information. Next slide again, please. Experience sensitive, mental well-being being vital. We need to make sure that autistic experience is acknowledged, it's validated, that people are truly feeling like they're experts in their own set of experiences, and that their expertise really is listened to and responded to. We've seen some places, not all, but certainly some places that have done too much of this, what I would call checklists of fixable behavior. And we've heard a little of that from the speakers so far. We need to move away from it, because autism has never been a behavior, though we might have seen a lot of distress from some autistic people. We need that curiosity and relationship. We need the trust building. We need the meaningful engagement within the clinical and educational environments. Next slide again, please. Moving on to a more difficult subject, but it's at the core of a lot of what we're doing, the subject of trauma. And again, we've heard about some traumatic experiences already. From research, it certainly looks like a majority of autistic people have diagnosable levels of post-traumatic stress, so that trauma experience, PTSD, certainly, if not right at this very second, within their past. And we're realizing from research, and I've linked to one of the papers here, that so much of this is somewhat different to the trauma that people were expecting. It's a wider variety of situations over longer periods that are really wearing people down and being traumatic for them. Years of pain, for example, from sensory overwhelm. Searing pain, perhaps, from medical interventions that haven't worked because we respond differently, or from restraint. Neglect. Enforcement of normalization, we heard a bit about that. Using often punishing procedures, and we're understanding that punishing autistic people can be differently received by us than it would be for others, like, for example, taking our precious stuff away to see if we can normalize ourselves so we can get it back for a while. That's not okay. Bullying, yeah. Sexual abuse, yeah. Also, deaths of deeply loved ones, abandonments by deeply loved ones. So many of these factors build into this real picture of trauma, which then people quote as behavior from autistic people. It's not behavior to do with autism, it's that lot. It's everything they've already been through. So we need to think about this. Next slide again, please. Thank you. That distressed behavior is an understandable response. It's not something we need to extinguish by saying, oh, how are they behaving? You know, what can we take away from them to make them behave better? Yeah, that's probably not the way we want to go now. Many are understandably terrified of being restrained because of either past trauma or because, for example, of co-occurring health conditions that mean it's really painful. For example, hypermobility, common with autistic people. And so all of our teams have this good training, this good grounding around truly trauma-informed approaches. Next slide again, please. Thank you. So what does a proper trauma-informed approach look like? Well, it looks like an understanding, that relationship-based approach, enabling safety, a respectful trust building, truly caring environments, enabling soothing, finding ways to achieve self-regulation in whatever way that is, sometimes by flapping or rocking or indulging in a particular hobby, finding calm and happiness again in our own best path to healing, and the best possible therapies for that person, working with them to find out what works, not just what it says on a piece of paper. And enabling sense making, working out what's happened and how to have the best chance of it never happening again. So my summary of our aims, what are we doing here? Well, we want autistic lives that are worth living. We want collaborative caring teams, and so many people do collaborate, they do care. We want to provide them with the best ways to do that, with mutual trust, with respect, and using that very best of the modern research, with autistic expertise and input which is truly valued and listened to, and informing excellent outcomes. Thank you for listening.
Thank you so much. We recognize at Autism and Freud Center here, we recognize that there is lots of good practice out there, but we also recognize the need for so much more to happen. Next, it is important to recognize that professionals, not just autistic people, but also autistic and non-autistic professionals, see the need for a different approach in inpatient care and community services. For that reason, we're going to hear from Mary Evans, who is a clinical director at Kent, Virginia Lumsden, who is emotional well-being lead in a community service, and Mike Hazinski, who is also working in a ward environment. We start with Mary Evans.
We were very interested in the training that At Autism and Anna Freud developed together, because our understanding was that it had been created by autistic people as well as professionals with experience, and autistic people who were professionals with experience. And our understanding was that that would be something that would bring a better awareness for the staff, partly because we wanted training that wasn't aboutness training, so people who came in and talked about autistic people as other. We wanted training where autistic people brought a better understanding for our staff about what the autistic experience might be like within a hospital environment. At the moment, we're waiting for the full analysis of the training to be completed, so I can't refer to the full analysis of the feedback, but very early on I was getting comments from staff about how important the training was, how it had really opened their eyes. And I think one of the things that the training particularly did, which I was very pleased about in my role as neurodiversity lead, was that it challenged some of the stereotypes that people had about autism, and it really improved their understanding about the strengths of being autistic and some of the challenges and very particular kind of nuanced experiences that people might have within hospital that people just haven't thought about or been aware of.
We have heard stories so far about inpatient care, and we heard Mary Evans, who is leading an inpatient care hospital service. But we are going very soon to launch also for the community, for community services, all ages. Let's hear from Virginia Lumsden, who has been leading an emotional wellbeing centre in the community of Kent.
As we move towards a needs-led approach to the provision of mental health services for children and young people, it's important now more than ever that people working directly to support children and young people's emotional wellbeing and mental health have a really meaningful understanding of autistic experience, which I think this training can provide. This informs the provision of individualised support, such as ensuring that focus interests are incorporated into everyday life and/or environmental adaptations are made to support inclusion. And I think hearing directly from autistic people about their experiences through co-produced and co-delivered training has an emotional impact that inspires change in our practice. So in my experience, the co-produced and co-delivered training was fantastic. It was an enriching learning experience, both in terms of deepening understanding of autistic experience in a way that impacted me personally, at the same time as translating directly into practice relevant for education settings. And the training really modelled compassion, curiosity and respect, which I think are the values that are really important in all of our work, but particularly in our work with autistic children and young people.
Next, I would like to invite Mike to introduce himself and tell us his experience of the training that he's also now co-delivering with us.
Thank you. Good afternoon, everyone. So yeah, I'm Mike Hazinski. I'm a mental health nurse, currently practicing, been working in mental health for about 20 years now. And it was an absolute pleasure to attend the pilot program. Okay. So on a professional level, I found the length of the program that I attended to be just the right amount of time for me to take a bit of a deep dive into expanding my knowledge of autism. Having reminders throughout the program that it's been collaboratively produced by neurodivergent, neurotypical, academic and non-academic people was really helpful. And in addition to this, having the chance to meet these people as well, to be in that virtual room, to be able to ask questions, gave it even more value. We heard about lived experience, some good, some bad, and that was also a real catalyst for reflection for me. The program really gave me an opportunity to consider my own practice as well, what I've witnessed, what I can start to change myself. And we were reminded throughout that it is those changes that we can make ourselves that matter. They're the changes that we can put into effect without delay. And with those changes, we'll start to see a ripple of change. On a personal level, I found the program to be emotional and inspiring. there was a safe and supported environment that was created throughout the programme. I was a little bit sceptical at first of how I'm going to get through this, being sat at home in front of my computer for hours on end, but that just simply wasn't a problem. I found that within no time I was immersed in this. It captured me. I felt safe. I felt safe to ask questions, safe to begin to understand a little bit more. In the breaks, I had time to mentally digest the information that I was being given. At lunchtimes, I'd go out for a walk with my dog and just be reflecting on what had been said, what had been shared, pick up the phone and call my mum just to talk through this and go, wow, what is this that I'm becoming a part of? Most importantly, I felt welcomed into a community that really want to work in a collaborative way to make some positive change. And that change, I know, and I've already seen, is going to have a massive impact on my professional and on my personal world. Next slide, please. So I was asked, what were my hopes for the course? What was my hope for the programme for humanising care and stopping restraining practices? My hope is for everyone that comes on this programme that it ignites and fuels a passion to be part of this positive and proactive movement that really zooms in on true person-centred care. Care that's opposite to what we've heard Lauren experienced, some of the experiences that Alexa's had, apart from that lovely hug that she mentioned. The programme asks us as nurses to embrace our core values, you know, that inquisitiveness that we have inside us, that curiosity that led us into this profession. By doing this, my hope is that we'll see a shift in attitudes that will result in our patients being handed back a sense of agency. As mental health nurses, we are trained in these fundamental skills of communication, having meaningful communication, empathetic communication, and that should be with every individual that we work with and their families and their support networks. And it's that communication that we really need to embrace to see the changes that we need to make. When we do this, we will see a result in more humanistic care being delivered. Care that empowers our patients to have their voice and choice listened to and not ignored. When we start to see changes in narratives that are being used for patients and a humanistic and collaborative approach being taken, I'm sure that we're going to see a reduction in restraining practices. The attitude and behaviour that we take to work with us, it affects how we practice as nurses, and it also then has a domino effect on how our colleagues practice as well. By adjusting the language we use, by reframing the way we hand over information about our patients, that's a powerful thing. And again, it's that thing that we have in our control. It's something that we can change very easily. Then we'll start to see more proactive, compassionate engagement with our patients. That will, I'm sure, lead to shorter stays in hospital and that reduction in restrictive practice that we currently see. Next slide, please. So this training was very different from other training that I've received. Having experts by experience in the room was incredibly powerful and absolutely necessary. It makes the programme what it is. I'm not autistic myself, therefore I have no personal experience of what it's like to be autistic. Without contribution from experts by experience, how could we possibly hope to get this training right?
it would be disrespectful and foolish to create and deliver a program without autistic people sharing their experiences, being in the room when it's delivered. That would just increase the chance of us doing what we've always done and carrying on getting it wrong. My autistic training partner is able to answer questions in training that there's no way I could answer. They're able to offer a depth to the training that's invaluable. Granted, this is just one person's view, but what they can do is hold a space in the room to respect the perspectives of autistic people, to make sure that they're heard and not dismissed. Together, we can challenge and we can question unhelpful attitudes in the training room. We can pull out the incorrect assumptions that are being made, and we can demonstrate together that this collaborative approach really does work. The emotion, dedication and power of this programme is palpable, and that is due to the fact that it's co-produced. Without experts by experience, it just wouldn't be the same, and it wouldn't have the depth that's needed. It's lived experience that informs us what's happening and what changes need to be made. Next slide. So I was asked why would I encourage people to join the programme? So I'd encourage all professionals who are feeling nervous about working with autistic people to register for the programme. I've been in their shoes. I've felt the stress. I've thought to myself, what am I doing? I'm out of my depth. This is not what I do. This isn't mental health. I'm all stressed out. Help me. Well, the help is here. This programme will help with those thoughts and feelings. The programme will show you that you're not alone. There's this community out here that's ready to accept us. Since I've joined this community and I feel welcomed by the community, I've found that it's positive, it's enthusiastic about making change, and that's infectious. And I just welcome anyone to it. I now see myself and consider myself as a more reflective nurse. And this has given me back a degree of control that I forgot I had. When you register for the programme, you'll be part of a practice. You'll be part of a change to practice that I believe will help everyone, not just autistic people. You'll be supported to help share your knowledge and the information that you receive with your colleagues. And we're not just here we're not here to change the whole healthcare system. That's something that I've understood. But, you know, as individuals, when we make those small changes, we'll see them ripple out, and collectively ripples will make a positive wave of change. Thank you.
It's beautiful to hear from Mike about how the training partners are modeling that sense of co-production and co-delivery. It's just easier, and it's good for everybody's mental health working together instead of beside each other. Thank you so much. So you have heard some personal experiences and perspectives in relation to the program, but what do the numbers say? What do the external evaluators have said about the program? The pilot demonstrated that the model works and that there is a need for established community of practice. So there's lots of learnings about what we've done, what worked, and what we need to do in order to sustain, to make change possible and sustainable. Over to Irina Nedelku, who is the project manager of the National Autism Programme.
Thank you. Thanks, Georgia. So as Georgia was saying, I was fortunate enough to be part of the team that supported the delivery of the autism inpatient pilot training that Anna Freud delivered in collaboration with Autism last year. Next slide, please. So the adult inpatient pilot was delivered to 4 mixed cohorts from London and the Southeast, and they undertook the 6-day training that Mike was talking about between February and March. In total, in the pilot, 56 staff attended the training from 8 different NHS trusts, and 51 out of the 56 staff completed all the 6 modules of the training. As you've been hearing throughout the day, the training was co-designed, co-produced, and co-delivered by autistic people, family members, suitably experienced autism and mental health professionals, and academics, several whom themselves are autistic. So autistic people are an integral component of the training and were fundamentally at the heart of the course development from the very start as the main contributors of content, co-designers, and in the sign-off and the delivery of the final content. As you can see in the image, in terms of the delegates' job titles, the adult inpatient training was specifically designed to meet the needs of a range of mental health practitioners working in inpatient mental health settings, as well as managers of inpatient mental health services. So this was reflected in the list of different job roles that the delegates had. Next slide, please. So in terms of the key aims of the training and then how these key aims were achieved. So the program wanted the delegates to understand barriers experienced by autistic people in the community and hospital environment. They wanted the delegates to employ experience-sensitive and reflective approaches of working with rather than on or for autistic people. They wanted them to gain expertise and a broad range of skills and practical strategies to meet the needs of autistic people and their families as members of multidisciplinary and transdisciplinary teams and wider teams of staff members. They wanted them to model values of collaboration and acceptance and promote a positive narrative about neurodiversity in their services and learn to speak autistic, as Andrew said, and to demonstrate an understanding of key concepts, values, and behaviors that were taught and how to best communicate these in their to their teams and in their settings. So all of this was achieved through primarily by ensuring that the autistic perspective was always present in the training room, both professionally and personally via content, the trainers and the co-leads. This helped delegates, from the feedback that we've received, this helped delegates to address common myths and misconceptions about labels, behaviors, and sensory or communication needs. And the training was designed to influence that change in the model, narrative, and culture of inpatient services, and ultimately to provide a more autism-informed environment in which to offer mental health treatment and support. The facilitation of a safe space, which is what Mike talked about, enabled attendees to engage with the training emotionally and authentically. The training focused on the importance of well-being of both patient and staff and recognized the pressures, influences, and the stressors on both. The training is both autism and trauma informed and created the space to listen to the voices of staff working in inpatient settings and enabled the delivery to gain detailed and valuable insights into the various challenges, stressors, that are involved in working in NHS settings, as well as potential barriers to implementation of the training back into their settings. So the train the trainer model to be implemented in the work settings of the delegates. So this listening dialogue allowed the development of approaches that could address these challenges at a local level, and attendees reflected on how this enabled them to connect with the learning in a way they had not previously experienced. Intersectionality. So attendees reported they found coverage of ethnicity and culture very helpful. And in the feedback and in the evaluation, it was our understanding that intersectionality needs much greater attention at all levels, including content and delivery, because we all know that the position of autistic people from Black, Asian, and ethnic minorities, as well as LGBTQI+ communities, is under-recognized, as well as those with multiple conditions and diagnosis. The use of interactive sessions. So the training curriculum included original and bespoke video content, direct tuition, dialogues, group reflection, and discussion. And it concluded with a final day of reflective practice concerning training methods and delivery, including the exploration of barriers as well as potential problems when delivering training back in own settings. These interactive sessions allow delegates to use the material of the course to develop their own nuanced and appropriate local and innovative approaches. One of the key recommendations from our own internal evaluation of the program, which was supported by staff who attended the training, was for this model of training to be made available to staff working in a range of other mental health related settings, such as children's mental health services, CAMS, community mental health settings, services offering talking therapies. So it is with great joy that today we're able to actually deliver across multiple settings. Next slide, please. I will like to leave you with a minute to read a few more quotes from delegates who completed the training. Thank you.
Thank you so much, Irina. It was very important for us to have external evaluation from the Royal College of Psychiatrists along with our internal evaluation, and to see how NHS, our funders, are supportive and are taking this feedback very seriously. Next, it is important to hear from Claire Evans about why this work is sitting particularly well with our mission at Anna Freud Center to aim to close the gap.
Thanks, Georgia. Thanks, everybody. I've been sitting here listening today, and thank you, Lauren, for sharing your story. Such a brave thing to do, to stand up and talk about what your experience is. Could we have the next slide, please? We had Peter Fonagy, our chief exec, talking about closing the gap and how we do that here at the Anna Freud Center. And listening to everyone today, this is not just a gap, this is a gaping wound between what we would hope people would experience from services and what they can actually experience. And why does that happen? Why is there a mismatch in how people maybe want to act within systems and then how they do act? We heard Alexis's story. It was inhumane. She was not treated like a human being. Why does this happen? We want to radically change that and ensure that people are thinking human being before anything else in the care that they give. At the Anna Freud, we're very proud to be part of this programme. And we really want it to make a difference. We really are full of joy working with Autism, our colleagues, and learning from them, but also learning from everybody that has lived experience and is connected to this programme. The Anna Freud does lots of different things. We might invent treatments, we might teach people to deliver those treatments, we gather evidence. We connect with our partners, with other people, with people with lived experience, and we try to influence national policy. And I want to thank Tim. I hope, Tim, you're still on the call, and Andrew and Hassan, another commissioner, and their big steering group on taking a chance on At Autism and Anna Freud, because we are proposing a radical approach to care and changing things for autistic people. And I hope that we can justify that faith that you've shown in us. Through closing the gap, trying to close this gaping wound and heal it in some human way, we really want to skill people up. One of the things that we learn time and time again here is that there can be fantastic programs delivering training to people, but it's the implementation of that training in practice that can fundamentally make the difference. And sometimes there's not a link. People go away for training, but then they go back into services and they're not able to implement their learning for lots of different reasons. So we want to do something different. By running a Train the Trainer programme, we'll be developing champions within services to radically change practice and be the champions for change within their services. We'll also be evaluating throughout. Tarina has talked a little bit about the evaluation of the pilot programme and the external evaluation, but we also will be using a tool called POD, which is people's outcomes data, which tracks people's experience of training in real time. So we'll have a feedback loop, which will tell us what we need to do differently. If things aren't landing properly, if they're not making the difference that we'd hope, we will be learning from it and adapting our training. We want to make sure that people who've experienced trauma, we've heard so much about trauma today, the people who've experienced trauma do not undergo more trauma from the services who are there to help them and to change things for them. Can we have the next slide, please? Tim talked a little bit about this earlier, as did Andrew. You know, time and time again, there are reports, there are investigations into things that go wrong and the care or lack of care that people have received. We know that autistic people die on average 16 years earlier than the general population. This should be a national crime. You know, why is this happening? Why are we allowing it to happen? We need to really challenge this. There's a CQC report in 2022, Who I Am Matters, and it talked about the care that autistic people might get within services. Next slide, please. And what it reported on was that there are some really good examples of care, and there are some teams around people receiving care, seeking help, who have expertise, but these teams are few and far between. And why should all the expertise sit in one team? We need to skill up whole teams. We need to ensure that everybody is thinking differently, having the right training and the right skills and knowledge to care and work with. And that working with is really, really important with autistic people. Next slide, please. So this is the bit that gets a little bit scary. In 2.5 years, we have to train up 4,800 people. Now, what's incredible, forget that number for the moment, because if we think about it too much, we'll just be floored by it. But what's tremendously exciting is that this isn't just mental health training. It's not just community and inpatient setting training for children, young people and adults. It's an expansion of the pilot. So it's moving towards youth justice and secure welfare settings and residential schools and colleges. And that's really, really important because it's a system approach. We don't want this training to just sit in one area, i.e. mental health training. We want it to be expansive. We want it to actually challenge the whole system where people experience care and services. So we're right at the beginning right now. You can see from in the room and hopefully people online, we have a very committed team wanting to change things for people. So hopefully people will sign up for the training and get really, really excited about what we're offering, and we will start to try and change things. And if we're not changing things quickly enough, we'll take feedback from people and we'll do something differently, because we want this to be a learning collaborative programme throughout. So thanks for listening today. I'm going to hand back to Georgia now.
Thank you so much. I'm going to invite now someone who is at the heart of everything we have been talking about, Dr. Ruth Moyes, co-strategic. Yes, I think it's you that I'm asking to come. Co-strategic lead, at Autism Director. It's a great pleasure. I could talk for hours. I'm not going to do it, about how nice it is to work with Ruth. And we're going to have 10 minutes break, and then Ruth is going to lead the discussion panel.
So we're going to have a Q&A. So if you have any questions that you haven't yet submitted that you would like us to answer, we have received a few already, but please send them in and we'll endeavour to get those answered for you after the break. Thank you. Welcome back, everybody. So now we're going to move to the Q&A session. So we've got a long list of questions here, and we'll get through as many as we can in the time available. So the first question, actually, do you know what I'm going to do first of all? I'd like you just very briefly just to introduce yourself and what your relation to the programme is, if you wouldn't mind. Thank you.
Of course, I'm a content developer and general source of some, but not all wisdom.
Hello everyone, I'm Chris Atkins. I'm a director at Autism, and I'm also the community practice lead.
I'm Georgia Papapoulou. I'm co-leading just like you, Ruth, and UCL Associate Professor as well.
I'm Lauren Rochelle Fernandez. I am an expert by experience, and when I return from maternity, I will continue to be a trainer on the programme.
Hello, I'm Richard Mills. I'm an associate at Autism, and I contributed to part of the development of the programme.
I'm Andrew Carpenter. I'm autistic and the autism lead for NHS in the London region. I'm very much enjoying the break biscuits.
Thank you. So as you can tell, half of our panel are autistic, as am I. So the first question is there any ongoing support after the training, and what support will be available once I'm trained? So Chris, would you like to take that one, please?
Oh yeah, we're planning on a series of shared learning events and community of practice seminars over the coming months. They will be advertised as usual. I think the important thing for people to try to remember is that we will be driven by what the trainer's needs are. So at this point, there's little I can say about what that's likely to be, although we are kind of dependent on all of the trainers feeding in to us to let us know where they feel they will benefit from support and guidance, and we'd be very happy to provide it.
Thank you. Georgia.
One of the things that is going to be part of how we support trainers is to connect them with the participation and Freud team, to connect them with autistic experts by experience, who will and create and bridge them and bring them together and create the necessary support so that in harmony they co-deliver and they bring back this learning to the wider team.
Thank you. Next question. Has the material been co-created by a range of autistic people, for example, working class, BAME, LGBTQIA, and so forth? Is it representative? So, and can I come to you first and then to you, Lauren?
Of course, I think the short answer is it's as representative as we can possibly manage. We've certainly got lived experience within those groups, and we have a much wider collaborative base to work off as well. So yes, we have put a lot of work and a lot of effort into making sure that as many groups as possible are properly and well represented and listened to.
Thank you. Lauren.
So as I've said, I am involved in the programme on the delivery side, and I have extensive knowledge of other people, particularly from Black and ethnic minority communities that have and continue to input into the content and the production of the course materials. Although you may not see so many other people that look like me, I can assure you that there are people that have been covered in a variety of backgrounds and diversity, and the focus on the intersectionality and the lens that is actually carried out throughout all aspects of the training.
Thank you very much. So next question is Tim online, do we know?
Yes.
Yes, fantastic. So question for Tim. My apologies, I missed the start. I'd like to understand how this fits with the Oliver McGowan training, and if the audience for this training is different from that for the Oliver McGowan training.
Okay, so the Oliver McGowan training is intended for all health and social care staff. It's been written as a basic minimum that anybody would need. So the tier 1 training is designed for anybody who needs an awareness of autism and an awareness of learning disability. So typically that might be somebody who perhaps works in accounts, for example, a nice obvious example of somebody who wouldn't necessarily be meeting the public. Anybody who might be responsible for delivering care to an autistic person or to a person with a learning disability should have the tier 2 of the Oliver McGowan mandatory training. So that would cover people like phlebotomists, it would cover people providing 24-hour care, it would cover GPs, it would cover mental health nurses, inpatient settings. So it's there, it's a basic for everyone. It covers some of tier 2, very few, but some of tier 2 capabilities. That broad level of training is fitting for a wide range of audiences, but there are additional capabilities and skills that people require when they're working in a mental health setting, when they're working in a youth justice setting, whether that be inpatient, that are in addition to the Oliver McGowan mental health training, and that's where this comes in. Some of those are additional tier 3 capabilities, some of those are additional tier 2 capabilities, but that's what this training is aimed to provide, that additional stuff for the Oliver McGowan. So yes, people will need Oliver McGowan mandatory training, and they will require this as well.
Thank you, Tim. So the next question, there's a few around this same sort of question actually, for people who work in inpatient care but missed the training last year, so can they attend now? And somebody else is asking, I don't work in inpatient care, when do you expect to have dates for the other strands you're delivering into? Georgia, do you want to take that question, please?
Yes, so the program is if someone didn't have a chance to attend last year during the pilot stage, they're very welcome to start registering. We have dates on our website that are coming up soon. People will be able to register online if they visit our website. And as I speak, probably one of my lovely colleagues is going to put the links on the chat. So you can find more information for bookings. So yes, you can attend. And if you did attend, but you feel it's been quite a long time, it's been now more than 10 months since the last time we were in touch, please do join us for the reorientation sessions. So we have some type of refresher for you to update your knowledge and to recreate your plans of how you can transfer this knowledge now to your service. Our training is very much expanding from inpatient care, and we're also covering, in inpatient care, we cover all ages, adults as well as children and young people services. And we're expanding into community services, again for all ages, as well as after July in youth justice and secure welfare and special residential schools. So there is a scope for anyone who is interested to understand autistic mental health, understand best evidence-based and humanized ways of working with autistic people, to join us. And most importantly, to then be supported to transfer this knowledge across your teams and bring the change that you want to see in your service.
Thank you. I think this is another question for Tim. Is there a cost to the training or a limit of how many places per trust?
I'm not sure that is a question. There's no cost to the training, to trusts for the training. I'm not sure how you're working out how you distribute the training to trusts. So perhaps you could answer that, one of the panel teams. But there's no cost to trusts or providers for the trainers training.
Thank you. Does anybody want to pick that up in the panel?
We recommend services to commission, to allow to send to the training 2 to 6 people, so that they feel that they have enough support, they can support each other, they can build strong reflections, and they can build a strong team to maximize the chances of transferring all that goodness from the training within their teams.
Thank you. Okay, next question. Will this training be available to specialist mental health teams, for example, early intervention team and psychosis based in the community?
Yes.
Can I answer that question? So the training's designed, the training's for trainers, and those trainers are then equipped to train in many different specialities. And so the idea is that you don't come and just access your bit. The trainers are equipped to deliver across a broad range of specialities that's meaningful and relevant to those services that they're delivering training into. And they might gain some of that specialist inside knowledge by coming from that area or having a deep understanding of it. And the training helps them understand how to apply the training in those specialist areas. So the answer is yes, but it's a caveated yes. It's more than just picking out individual services.
Thank you. The next question. I work for an intensive support team for people with a learning disability. However, we have many clients that have learning disabilities and autism, and the level of learning disability means they are able to be admitted to a mental health ward. Our learning disability services get utilised a lot for advice surrounding these. Would this be an applicable course?
Thinking about it, yes. I was struck by the comment that Mike made earlier that part of the course, and I think a big part of the course, is getting people to reflect. And I think that certainly when we're meeting some of the people who might have intellectual disabilities and autistic people who might be highly stressed, one thing that we do need to do is to reflect and take some time so that we don't behave emotionally in those circumstances. Is there a formula which you can download to use with people with intellectual disabilities? No, I don't think there is, but I think that the emphasis of the training on reflection and taking stock and standing back and taking time, being kind and being calm and being patient, I think all of these things will be highly suited to that constituency.
Thank you. Next question. How will the training be made accessible for autistic and ADHD/DCD/dyslexic, for example, learners? Who would like to take that one? Georgia.
The joys of vast majority of us being neurodivergent, it means that we have time during the curation of the material to audit as much as possible different styles in terms of presentation and curating the material that matches neurodivergent delegates. Of course, it's always work in progress. We always welcome feedback on that. And across the training, we do cover all that people need to know around autistic mental health, but also common companions. So learning disability, ADHD, dyspraxia, dyslexia, and so on. People will have a chance to contact, once you register, you will be contacted by our team of project managers to understand your own needs. So if we know in advance what you need, it might also help us to individualize and adapt the material to your needs.
Thank you. And finally, we have a few questions asking for a few more practicalities around the training itself. So what will that involve? What will that look like? We've heard a bit from Chris about the community of practice and the follow-up support, but what will the delegate experience be like? How many days? How will that look? Would like Georgia, Richard, would you like to pick that up? Either of you?
I can start.
I think Georgia is the expert on.
I can start, and you feel free anytime to join. So we have a range of trainings from 2 to 4 and 6 days. There are days that you have to attend, and hopefully you will find them meaningful and join other optional days as well. A typical day lasts from 9:30 to 5, and you will have lots of breaks in between, including 1 hour lunch break. And different days will have different threads across the day. You will learn all things neurodiversity, autistic mental health, common companions like ADHD. We will look at how the specifics around how autistic people may experience anxiety, depression, or asthenia, and what factors, what knowledge do we need in order to be able to understand autistic mental health and to create a collaborative, truly authentic collaborative process to work with them rather than on them or for them in their care plans. Much of what we're doing is not just purely didactic. We place lots of emphasis on creating a very safe space for professionals to reflect in their own practice, as well as, because remember, these people are going to become trainers in their own settings. So it's really important for us to model to all of you to join. What is it like to share the space, a very neurodivergent space? You will have trainers who are autistic. You will be exposed to material that has been exclusively authored by autistic people. You will look at different animations and videos, and we will have lots of space for discussions and reflections. In my experience delivering with Dr. Ruth Moyes, the pilot, it was really important for professionals to have that space to talk about their common worries, to celebrate their successes. We know that there are tons of good people out there trying very hard to get it right. In many occasions they do, but also we do know that people are often burned out, are often exhausted, and they need that space. One of the threads across all days of our training is that we look at, when we talk about mental health, trauma-informed and well-being approaches, we don't just focus on the patients, on your clients. We focus on everyone's well-being. It's highly unlikely that a very anxious, traumatized, burnt out member of staff is in a good position to offer good care. So we look at that holistically.
Thank you. Anybody want to add anything?
Just to emphasize, the well-being is more likely, I think, to lead to well-doing. You know, I think there's quite a bit of evidence for that, and reducing stress in staff. The other thing that struck me during the pilot is just how different the courses were, even though the content is the same. Because the people were different, they were able to bring different stories, different contributions, different issues, which could then be talked through. And we were able to listen to those and to change some of the content. So they were very dynamic and constantly evolving courses, even though the content remained fairly consistent.
Thank you.
I think as well, Ruth, that that's the kind of thing that we'll need to follow up in the communities of practice when we try and support the learning that's gone on, try and support the trainers to be effective in delivering the skills and the experiences that the trainers that we're hoping to support will need to deliver themselves.
Thank you. So my next question is to Andrew, actually. Do we really need diagnoses and labels, whatever they are, to provide more humane, person-centered care and trauma-informed approaches?
Oh, what a good question. One always likes to think not, but I think we live in a system that does demand those things, doesn't it? These things do open doors for people. You know, we're meant to be working in a way that is needs-led rather than diagnosis-led. I don't think we're there yet, sadly. I do think, you know, we're also in a world in which that, as I said earlier, the narrative is changing through the voice of the autistic people. So I guess what I'm coming around to saying is I don't think of autism as a label. Think of autism as an identity. And I think that if we can, through training like this, through that, you know, the autistic voice coming through, seeing autism in a different culture, a different language, if you like, we can start to change what we hear when we hear the word autism in the first place. So we don't think of it as a label, more of an identity to be celebrated rather than treated. I hope that's a sort of answer.
Yes, I'm going to come round the panel actually, I think, on that one, Richard.
Absolutely agree with what Andrew has said. The other thing that was made clear to me some years ago, this topic came up at the all-party parliamentary group on autism. There was a young man there called Richard, and he was asked exactly this question about labels. And he said, in my case, he said, it's not a label, it's a signpost. He said, and it's not just a signpost for other people. He said, it's a signpost for me. He said, because by getting this diagnosis, I've been able to meet a lot of other autistic people that previously I didn't know existed. I thought I was the only one. That's another important consideration when we're talking about diagnosis.
Thank you. Lauren, do you want to mention?
Yeah, so coming from marginalised communities, label is not something that is necessarily accepted and discussed, particularly from where I come from. And it's not something that's been supported in me to have. It's not something that holds back much value to my family and my support network. As I mentioned earlier, or touched on briefly in my experience. However, as my colleagues have said, it has enabled me in particular in my experiences to navigate myself out of those dangerous situations and to be able to say, this is my identity. And although I have found myself in a position in inpatient care where I would expect mental health professionals to understand what autism was and how that may manifest, unfortunately, as a Black woman, it's not seen, it's not completely and wholly seen, and it's not understood. And therefore, if I didn't have that knowledge and those labels and diagnoses, then I wouldn't have been able to advocate for myself, and I wouldn't have been able to articulate myself as to the challenges that I was facing, but also why they were wrong and why I shouldn't have been going through those things at those times.
Thank you very much. Would you like to reflect on that?
Yeah, I would. There's so much to reflect on. I think you could do half a dozen theses on something. But autism, certainly, it's in part identity, but from a clinical perspective, I'm not a clinician, but I am a researcher, and so I provide research to those communities. We know how important it is to understand that we have an autistic person in front of us, or someone else who is neurodivergent in the wider sense. We know there can be differences in presentation. We know there's differences needed in pain scales. We know there's differences needed in quality of life reports. So everything we do is in collaboration with that kind of information, that understanding of identity, but also the understanding that this is a different neurology. So yeah, I think it's vital that we know.
Thank you very much. Any further reflections before Georgia?
I think it's really important. Very often we see the inquiries, for example, we're receiving. That sounds interesting, but we're not an autism specialized unit. I think it's really important to explain to people that they work with many more autistic people currently than they think they do. So this training is supporting you to support your team to work well in ethical, evidence-based, accountable ways with people who are under your care, who are diagnosed, but also undiagnosed. There is emerging research that says 1 in 5 people or more in inpatient care particularly is undiagnosed autistic. And if you're able to pick up on that, if you're able to facilitate a very smooth and meaningful diagnostic process with that person, it can be life-changing according to what we hear.
Thank you. And finally, Andrew.
Oh, Georgia kind of said it for me, but I'm going to build on the figures you gave. It is only anecdote because data is so poor and because autism remains so misunderstood and under-recognised. Anecdotally, we currently think that about 1 in 4 inpatients in London at least are autistic, and people are reporting back from talking therapies, we previously mentioned IF, but perhaps up to 50% of their high intensity users are likely to be autistic.
although those people may not even know it themselves. Massive overrepresentation.
Can I say something?
Please do. Yeah.
I just think it's important we acknowledge the role of language and the narrative that's associated with autism. Autism as a clinical condition is actually autism spectrum disorder. And as long as we carry that kind of language around with us, then I think it's going to have a significant impact on how people understand and react to it. I just wanted to add that.
Well, it's really important. It's a really important point. Language is very powerful in framing and creating the narratives that we live with. Thank you, everybody, for your time on the panel. So just a very big thank you, first of all, to the teams that are in the room with us today and our important guest speakers, and for all of you who are out watching all over the world, actually, to hear about this programme, and hopefully because you want to be part of the change that is so much needed. Thank you for your time. We do hope that you will visit our website and get enrolled on the programme. We will be releasing more dates really, really soon, so please keep your eyes on that.
Just to extend my thank you to our internal teams that are supporting us, to our content developers, and a big, big thank you to team and to the NHS funders, not for the obvious reasons that they have funded us, but also because it's a very collaborative process so far. We really enjoy working together. We see how much value there is in collaborative practice. Our experts by experience are working closely with the NHS, our co-production teams, and we're trying hard to get it right. And we will have good measures to measure the outcomes and understand what more is needed for us to support you, to support those under your care.
Thank you very much.